Good evening, everybody. A very warm welcome to the webinar on the front line with the Royal Flying Doctor Service in Australia. I'm Peter Box, and I chair the Royal Flying Doctor Service Friends in the UK charity, and I'll be your chairman for this evening's event. We were inundated with registration, so the last count we had about 230, which is fantastic, and I think a recognition of the regard that's held for the Royal Flying Doctor Service. It's essentially a Q&A, a question and answer session to the panelists, but I'll give you a few bits and pieces of information about RFDS Friends in the UK first. So we were set up in 2003 as a charity, as a tax-effective way for expat Australians and UK citizens with a strong connection to Australia to make donations to the charity, which we then send them off to the Flying Doctors Service in Australia. Our patron is His Royal Highness, the Prince of Wales, who's a great supporter of ours, and whenever there's a royal visit to Australia, there's normally on the itinerary a visit to one of the facilities of the Royal Flying Doctor Service. A few years ago, he dedicated one of the aircraft in recognition of the work done by the charity here, called Friends in the UK. Our vice patron is the current Australia's High Commissioner to the UK, His Excellency the Honourable George Brandis QC. And I understand George is on the call this evening, so welcome, George. So the Southeast section have been fantastic over the years. They were involved in helping us set up as a charity in 2003 and provide a lot of support to us. Since then, two of their board members are trustees in the UK, and they help us out with Facebook and Instagram posts, etc. So the webinar will last about 45 minutes. It's being recorded so that we'll be able to post it to our website and the Britain Australia Society website in due course. So I'd like now to introduce the panelists to you. So we have the Chief Medical Officer, Dr. Randall Greenberg, who's in Dubbo this morning. We have the General Manager for the Health Service, Jenny Beach, who's in Broken Hill. The Mental Health Manager, Vanessa Latham, who's in Lightning Ridge. And Emma Osman, who is in Clare Valley, of all places. And so she's struggling half an hour earlier than most of us. Before I go any further, I just want to thank our sponsors, BDH Sterling, for their generous contribution to allow this to happen. It covers the costs of putting on this webinar in the UK, which means that any donations raised through the webinar, as a consequence of the webinar, will be remitted 100% to Australia. So you've got your Q&A button on your screens there. Please feel free to send the questions through as they arise, and I'll do my best to get one of the panelists to answer them. But I've got a couple here to kick us off. And the first one is to Randall Greenberg. Randall, the emergency retrieval is probably one of the best known parts of the service, but I'm sure there are some challenges in delivering that. So perhaps you tell us a bit about the emergency retrieval.
Yeah, so we run a service whereby we're available to answer calls or emergency calls for people on remote properties. So someone falls off a horse or gets bitten by a snake, or more likely sort of has an accident on a motorbike. They ring us, and we will obviously endeavour to get out there to pick them up and take them to the appropriate place. But that's got its own challenges. So depending on where they are, a lot of the properties have got their own airstrips, and which we can land on. Some of them don't. So there's the whole logistics. So there's the medical logistics. You know, how do we give advice about what to do and how we can help them. We have this great system of medical chests whereby there's medical chests dotted throughout. We've got hundreds just in our section, New South Wales and South Australia, whereby there's drugs that we can prescribe, like antibiotics, and lots and lots of drugs. So we can offer that help. And a lot of the stations have got those medical chests. They're specific for RFDS. But then the other problem is logistics. So we've got to get the person to the nearest airstrip. We will not infrequently land on a dirt strip somewhere. Someone will pick us up in a ute, and we will go to the site and actually load the person on the back of a ute or a truck, and then bring them back to our plane. I'll just give you one little anecdote which happened a couple of years ago, but it was someone fell off a motorbike, and they were in southwest Queensland, but that's sort of in our area, that was sort of serviced by Broken Hill in Western New South Wales. There were logistical nightmares trying to figure out where to get this bloke to get some help. There was a nurse from Birdsville, travelled to meet him. We then figured out the best property where he could be taken. So they took him to a property. This took several hours. These things often take hours and hours to get to people. They got there, and the fellow was just on the kitchen table, as you do. He was quite unwell, and he just kept saying to the doctor, "I can't breathe, I can't breathe." The doctor correctly diagnosed that he had what's called a tension pneumothorax. That's where there's a punctured lung and there's like a valve, and it's life-threatening. So he had to put a chest tube in this guy's chest, and did it, and it was actually literally life-saving, and it was a good end to the story. But the best part about it is when the doctors were relaying the story was that in the background, because he was on the kitchen table, the mama was actually cooking lunch. So she was cooking lunch while I was doing this life-saving procedure. So they're the sort of things that sort of are a bit interesting.
Life's got to go on.
Yes.
Jenny, the Royal Flying Doctor Service does a lot more than just emergency retrieval. Can you give us a bit of an idea of the scope and breadth of services that they offer?
So I can. I've actually worked with the Royal Flying Doctors in some of those remote locations as a nurse. I've been there. I've had patients that are deteriorating, and you just feel the relief when you hear that plane coming over. It's quite incredible. I've had family members that have been carried quite ill, by the Royal Flying Doctors. So I kind of sense that and I understand what it does from a couple of angles. What I think is really quite amazing these days is that we will take every single day, we take a team of people out into the network. So that's a doctor, that's a nurse, it's mental health team, it's dental services, it could be an Aboriginal health worker. And we actually take them out to the network where we go to small communities and we care for those people basically throughout their life. So we become their health service. And it's quite incredible. We are the only people who go out there and do all of that care, what we actually term as primary care. So that is on top of a lot of the emergency and retrieval services.
And I suppose there's a bit of a theme coming through of what's changed in, say, the last 10 years or so in the breadth or the depth of services. Yeah, that's for you, Jenny.
Yes, definitely. We've seen an incredible growth in primary health, and what we're aiming to do there is, yes, we will always come and we will always pick people up when they're ill, but on top of that, we're actually trying to care for people so their health is better throughout their life. And the services that we're doing in that area have grown dramatically in recent years. If we can actually keep people in better health, stop diseases getting worse, all of that sort of thing, we can actually keep people living at home, living in their communities for much, much longer in their life. You know, we're looking after people like from when they're born right through till the end of their life now.
Yeah, an absolutely fantastic range of services in order to fulfill that sort of lifetime care. Over here in the UK, we've experienced quite a lot of trauma and with the coronavirus and its restrictions and the implications. And one of the big issues, and probably going to get bigger over the next few months, is the mental health of not just the people who are closely associated with people who have had coronavirus, but any just working environments and home and that sort of thing. So mental health is a big part of the agenda here. So over to you, Vanessa, being the mental health manager. What sort of things are you seeing from challenging the mental health world in the remote parts of Australia?
Yeah, hi. I guess it's just important to recognise that everyone has mental health, you know, and we all can experience periods of mental well-being and also are vulnerable. And so, yeah, this 12 months has been particularly tough all around the world. And for our patch out in the far west, while there's been a sense of safety for people living out on the stations, quite isolated from other people, that particularly has had an impact on the children. They're already schooling via the air, school of the air. They don't get to see their peers all that often. And this last 12 months, it's been much less again. And that's really sort of taken a toll, I think, on the kids, let alone the pressures just in the general family, household, business, generational.
And what sort of programs are you putting in place to deal with those sorts of issues?
Yep. So I very much try and sort of look at the promotion, prevention, treatment and recovery. So we have a team of multidisciplinary mental health professionals who fly out with the GP to the primary health clinics. So every single clinic around the Far West area has access to a mental health professional. We're trying to really grow our child and family mental health programs because we really see that's there's a lot more work to be done, particularly with children. We also have drug and alcohol counsellors. So we do a mix of the one-on-one counselling, but also a lot of health promotion events. And I guess the biggest thing is just trying to get to know people that live out there in the communities and on the stations so that if they need, then they already feel comfortable with us and they can reach out already knowing us.
I think that's a nice segue into Emma Osmond, who's got an interesting background to her screen, which I can certainly read it. We've got your back. Emma, would you like to talk us a bit about how the program works, what it is?
Thanks, Peter. I look after the We've Got Your Back program, which is a peer support mental health program in the far west of the southeastern section. So forgive my geography and my Google mapping skills if they're lacking, but we have 6 ambassadors, so they're graziers who are throughout the far west of New South Wales living on properties, pastoral properties, and they've been identified by the service. They've had a long relationship with the service in some capacity, and all 6 of those graziers are people that have either had lived experience with mental health or have experienced adverse adversity with regard to their health and have demonstrated positive coping strategies, and then have gone on to share their experiences and advocate in their communities and help others. So they were already demonstrating these attributes in their own communities, and as the drought kept persisting in 2018, 2019, the peer support model was seen as an effective model that could help others out there, and we now provide training to those people, and they advocate in their communities and provide linkage to the services that both the RFDS offers, but it's other services with regard to rural financial counselling and that sort of thing. I did look at, like when I was saying about my Google mapping skills, we say that our advocates, our champions, spread over a footprint of 250,000 square kilometres. And last night when I was doing my Googling, it told me that the UK is approximately 250,000 square kilometres. So forgive me if that wasn't accurate, but I thought if it is, it's a very interesting statistic.
So your territory is covering all of the UK. That's pretty impressive.
Yeah, and I think what you're alluding to before, Peter, is that I, prior to being in the role as the project coordinator for We've Got Your Back, I lived on a remote cattle station, so where Queensland, South Australia and New South Wales meets. And as Vanessa said, she was saying a lot of what we do is out in communities when people are well, forming relationships and connections, because our hope is to keep them well throughout their lifetime, as Jenny said, and a lot of that is in that preventative space. And I did move up to that cattle station back in 2013 with a small baby. So my first child was 10 weeks old, and that property was 500,000 acres in size. So again, if my Google skills are correct, it's actually 1.2 times the size of London. So that was just the cattle station, and we ran 5,000 head of cattle. And at the end of my about 6 months on that property, I attended an event, and a mental health nurse from the RFDS spoke at that event. And about a month later, when I was back at the property, just because I'd always been in a career and in a town, and I was faced with a set of circumstances I'd never come across in life. And I drove 120 kilometres, which on those roads is about an hour and a half. I got to mobile reception because there was no mobile reception for that whole journey. And I Googled RFDS, and I got reception, and I asked to speak to the lady that spoke at Channel Country Ladies Day, which was the event I was at. And then I was connected with Vanessa that day, and so I was a consumer of the service back in 2013. So when we talk about keeping people well and being out in community and seeing people, it's very important that we're active, because those connections are the connections that can help people when they're really in need.
Thanks, Emma. That's fantastic. One of the questions that's come through that it's probably down the track a bit for you guys, but maybe not, is what will be the RFDS's role in the vaccine program? Coronavirus anti-vaccine program.
Yeah, so we're a bit behind the UK, so we're just kicking off now. But yes, we will be heavily involved. Someone's got to actually provide the vaccinations for people in remote locations. So we put our hand up to do that. And we've also put our hand up to help with the logistics of flying teams and the vaccinations to remote locations and the smaller towns to vaccinate the towns. So with our primary health team. So yes, we're we hope to be heavily involved with that.
And Vanessa, another question to you from Robert. He was asking what sort of stigma is attaching to people with, mental health issues in the bush? Yeah. And is that a problem that's getting easier to deal with or harder?
I think it's getting easier to deal with, particularly in the far west, because of the amount of presence we've had and consistency, and particularly now with the We've Got Your Back program, where it's their peers standing up and publicly talking about their own lived experience, sharing that and advocating for the health and well-being of others. In saying that, I'm in Lightning Ridge today. This region's a newer region that our mental health team are building service delivery into, and I think this region's had a lot less mental health promotion, I suppose, and education, and it just seems 10 years ago compared to the Far West in terms of that mental health stigma. So it's interesting working, it's interesting looking at that, sort of working in 10 different years apart, depending on the location I'm in with regards to that. So,
Excellent.
The peer program is definitely a huge, it's just a huge benefit.
Yeah, and it has the feature of a multiplying effect. If I'm getting it right, that you're not reliant on 6 or 8 mental health workers from the Flying Doctor Service. You're actually spreading that out massively, and to people who they trust and they can confide in. A question for Jenny: how do you help people help manage their own health problems in the remote areas? Now, that might sound a bit like double Dutch, but I've got the question right. There's been probably looking at the educational aspects.
Yes, definitely that's a big part of it. I think there's a whole range of things that we do. I think what's really, really important is that we provide some sort of continuity so that we're caring for people throughout their life. That enables us to do the education part of it, to help people sort of look after their own health, to live the healthy lifestyle, to diagnose things early so it can be managed. And I think that's what's really, really important within that, is that we actually have people who go to those communities and get to know those patients. They know the community, they know what it's like to live in those communities, what it's like to raise a family in those communities, and just how far it is sometimes to go to get help. We talk a lot about access to things, and that can be looked at in 2 ways. That can be looked at in how far somebody's got to go to get to a service, or what services come to them. So there's kind of 2 aspects. What we do is try and bring those services into those communities. So our aim is really to make sure that we're delivering services and people don't have to travel further than about an hour to get to a service. That's what our ultimate aim is.
Excellent. And I was looking at some of the questions, and you may have mentioned this, but does telehealth play an increasing part of the services that you're offering?
Yeah, it does. So we've seen during the last sort of 12 months or a bit more, we've seen a lot of focus on telehealth. What I think that's done a couple of things. We go and we use telehealth. We've introduced telehealth, but in addition to face-to-face. So we see that it will build on and assist rather than replace current services. And I think that's really, really important. What telehealth enables us to do is to provide those additional services. So if we're caring with somebody who has a chronic disease or something that's going on throughout their life, we can see them via telehealth in between the face-to-face visits and the assessments. And I think we've seen a great acceptance of telehealth during this last period, a greater acceptance. But our philosophy is that it won't replace face-to-face, it's to add to the service.
Great. This is probably a question for Randall. There is an increasing use of drones to deliver medicines and whatever in the UK. Do drones have any application in the remote parts of Australia?
We actually have looked at the use of drones, but early days, and we actually haven't taken it up at this stage. But we have sort of had some initial discussions and inquiries about using them.
and again, this might be a bit early for Australia, but in the UK, there are minority groups, mostly ethnic minority groups, who, for whatever reason, and it's partly to do with their culture, have been resistant to taking on the vaccines. Is it too early to get a sense of that? I mean, in the Indigenous population, for example, would you expect that there'd be any problem with vaccination?
Probably a bit too early to see. I don't think there would be a cultural problem with the Indigenous population taking the vaccination. Jenny, would you agree with that?
I do agree with that. The populations that we're working with, the Indigenous populations, have been right at the forefront of everything that we've done. I think that they will welcome basically us assisting with providing their vaccinations as soon as it's possible.
And it's important to note that we have been scared as anything of coronavirus getting into these remote communities with large Indigenous populations, because as we all know, the virus, well, people do a lot worse with certain populations, and we're worried that the Indigenous population who have got well acknowledged terrible health problems would be devastating. So we've managed to keep it out of those remote communities. So I think what Jenny said is right, that they would welcome it.
Yeah. So the Indigenous populations, we've worked very closely with them. We have surge plans where a lot of the elders have been involved in, and look, there's some incredible stories. I was on one call where basically it was the elders deciding that they didn't want anybody coming into their communities. They just wanted to close the borders and close the town off and that sort of thing. They have literally met people off the buses and told them to get back on and things like that. Their own relatives sometimes, because they've come from difficult places. You know, there was one that I was on, and there was two ladies, two elders from the community who were on the call, and they were basically saying, we will do what we need to, we will tell people what, but you've got to back us up to the police. So it was this incredible relationship, and it just, you know, the strength and their commitment and their decisions are the right ones. So we've worked with those communities all the way through this.
Excellent. Well, you've probably answered this question, but the question is around with the agile technologies and agile methodologies and modern methodologies these days. Will the flying doctor service change much? I mean, I think, Jenny, you were very clear, and Vanessa very clear, that face-to-face is still an extremely important delivery mechanism, but perhaps I'll leave it to you to answer that direct question about changes in technology and etc.
So some of the things, I mean, I think this probably comes into a couple of areas. It does come into a lot of what we're doing in emergency and retrieval as well. But I think where we've really developed in the last 12 months is we've been able to purchase and buy quite a lot of additional equipment. One of the areas that Randall spoke about earlier was our medical chests, and we're about to add a kind of an iPad contraption to our medical chests, so that when people, you know, they can actually talk to the doctor, they can show the doctor things with the medical chest when they're prescribing. So you can have somebody that's hours away. We've got, you know, some of these medical chests are literally thousands of kilometres away from the doctor, and that doctor, you know, will be able to actually talk to them, see them, view some of that stuff before they actually prescribe. So look, I think sky's the limit with this. I think there's huge things and huge progress we can make, and it's about, we're actually very, very grateful to a lot of the people that have assisted us in buying some of this extra equipment, and it's helped us through this COVID period, and it will help us long into the future. And Randall, you may have some comments.
Yeah, can I just say, we have a philosophy in our management team that we have to move with the times. So there was a question, I think someone had worked at Kalgoorlie in the 1970s and how it's changed. Yes, it's changed a lot. in some respects, no, we still fly out and treat sick people, but we want to see ourselves, and we do see ourselves as a contemporary health service. And so for retrievals, we see ourselves on par with the top retrieval services in Australia and indeed around the world. So our staff are probably more highly trained than in the 70s for doing emergency retrievals. And also with our primary health team, we want to be contemporary. And, you know, general practice, primary healthcare has changed a lot in the last few years. And we certainly believe we want to be contemporary and change with the times.
And just while you're talking about that, the clinics that you run out in the bush, what would be the typical complement of the team that would go out to a typical clinic at Tibooburra or somewhere remote?
Jenny?
Yes, so we would take most days, there will be a doctor, there will be a primary health nurse, there will be staff from the mental health and drug and alcohol team, there will be dentists, there will be an Aboriginal health worker, and we add other positions. So sometimes there might be a women's and children's kind of somebody that specialises in that area. And it really just depends on what's going on in that community. But that's the kind of key positions at the moment. We'll often also take other allied health staff that may come from the local health district or other places.
So you're basically a mobile doctor's surgery.
It's actually
with allied health.
Yeah, comprehensive health service is what we're really aiming to be. So we can deal with all parts of people's health when we go out. Excellent.
I'm struggling here to get all the questions looked at. Yeah, there's a question of how many Indigenous staff do you have on the team? And this, I know we're only talking about the southeast section, and you can probably replicate your position throughout the service, but just in the case of the southeast section.
So we should have the exact numbers, but we actually aim to have, we have a reconciliation action plan, and I think we've got 3-point-something% of our staff that are Indigenous at this time and that identify as Indigenous. We're actually quite pleased with those numbers. Vanessa, you may be able to add something there.
Oh, I'm not on mute. I thought I was. No, just that, yeah, we do have quite a number of Aboriginal health workers and partner with other organisations and staff in the communities as well, because it's very important. Often if we're home visiting and things, we'll go out with an Aboriginal health worker or an Aboriginal staff member of a little health clinic in the community, because it's just much more culturally appropriate.
There's a couple of, well, there's the logistical point about with the aeroplanes, and I know you've got different sizes of aeroplanes, but for a plane that's been configured to carry the maximum patients, I assume you've got 1 or 2 on stretchers, how many patients can you carry in one plane?
So we've got 2 stretchers, so we can carry 2 stretcher patients, and we can also, along with that, carry 1 or 2 sitting patients. That's dependent on the acuity of the patient. So if you've got a patient on a ventilator, we usually try not to have another patient there. But we do have 2 stretchers and 2 configurations, so we can carry 2.
Question to both Vanessa and Emma is the funding for the mental health services that you offer, and perhaps Vanessa first. Is it part of a secure funding arrangement from the federal or state government, which is then topped up by your donation capacity, or how does it work?
Yeah, so we have a number of different funding streams for different programs, but they pretty much all are annual contracts, and we definitely have enhancement funds through the RFDS donations. Yeah. So yeah, the funding cycles are a struggle. We've been very fortunate so far that a number of our annual contracts have extended now 3-4 years, but it's every year. There's no guarantee. So we're very lucky to keep our staff too during those times.
But I thought that I read something about that the Prime Minister had to say about the impact of coronavirus and other things in the drought, the bushfires, was really showing up the need for more mental health facilities. And I sort of took the lead from that, or the assumption from that funding might be on a more long-term basis, but has that not materialised?
No, not long-term, no.
No. So, Emma, with you've got your BACK program, is that a funded program by the government authorities, or is it something that the flying doctors are doing themselves?
So currently, we were very fortunate and received drought funding from the New South Wales government. So it is currently funded under the drought funding model. Right. As we know, impacts of drought with regard to family units, finances, personal impacts of that will be felt for a long time to come. As Vanessa said, it is short funding cycles, so there is no guarantee. But the RFDS is committed to delivering the peer support model as an extension of the health service. But yes, as we said, there's no guarantees at this point into the future.
I think that's a good segue into a film clip that we have for the audience to see. It's about just over 3 minutes, and it is on the subject of mental health, but I think it's a bit of a different angle from what one would traditionally think was covered in the mental health arena. So it's the Mannion family, and over to the technologist to run the short film. It's probably been shown to the audience, and I can't see it. There we go.
It's pretty gut-wrenching when you're feeding your stock all the time and you go out there. And, we're doing our best to keep them alive, but to what end? Because it's sort of, if we feed them for another month and you feed them for another month and you think, is this enough? Is this enough? We know with this lifestyle that there's going to be drought. It's not a question of if we will, it's when we will. It's just how it goes. But you work every day for your good season, and then you can give your kids this amazing lifestyle. Not being from the land personally, I have had to adjust every day, and every day for me is learning. And then having 3 small children now as well, it's tough. It's not easy work, but I have a very supportive husband, and knowing that I've got him too, that's amazing for me. Yeah, so it would have been mid last year, I noticed with Imogen that she was having a few behavioural changes. She was having outbursts with her younger brother, and also her hair was thinning. It was actually my husband that noticed it first. He went to get her out of bed one morning, and when she was getting out, she sort of unrolled her hand and there was a clump of hair in there. And it wasn't, just a tiny little ball, there was a fair amount of hair. It got more common that in the morning she was having clumps of hair in her hand. And then particularly when this real obvious thinning spot on the back of her head started to get worse, it was just a triggering thing where I was like, right, we need to pinpoint what's happening for Imi here because something's not right. So we took Imi in, she met Leslie and she was happy to stay, play, and it went from there. We booked in for 8 sessions and it turned out, it was the best thing we could have done for her.
If I was talking to a child and a child asked me what play therapy is, I would word it in a way that we all have this stuff. And there's this stuff in some of us that we don't quite understand sometimes, and that stuff's those feelings. For us as adults, we might go to someone and talk, to a counsellor or a psychologist, and we can talk out our feelings. For children, the safe space for them is to play it out because they don't have the language that we have as adults yet. As a play therapist, I'm there to support them to heal through that play and to understand what those feelings are and to help them problem solve on how they might approach those feelings at different times. And it's all done in the world and the culture of play, which is the best language that any child can have.
It wasn't something that I thought would be the answer to our question, but as it turned out, it was. We found out that as she was taking on our emotions with the drought, what was happening at home, we didn't realise that she was having such a physical reaction to it, which I guess you don't think about with a 5-year-old. You think that things just sort of, water off a duck's back with kids. So at night, because she was, in a deep sleep and she was getting anxious about it, she used to rub her hair and pull it out. And now, her hair's growing. We haven't had any clumps of hair. We haven't had thinning. It was amazing what those sessions did for her. If this had happened 2 years ago, we would have been going to Adelaide or Sydney for the help. And now we've got this service in town. It's invaluable.
Quite an intriguing story and something that we don't really think too much about. I certainly wouldn't have thought it would have impacted on a 5-year-old in that sort of way. Vanessa or Emma, do you have anything to add? Vanessa or Emma?
Yeah, like we said, I think it's just, as Jenny started off with, our aim is to keep our communities well. And if we look at that from an Australian scale, is the communities in our rural and remote Australia, and the communities that out there, they're supporting the people in our country that provide the food and fibre that feed and clothe Australia and support our economy. And I think it's in the best interest of all Australians for our communities to stay well. And that's a beautiful, perfect example of helping Imi and helping a whole family through helping a child.
Yeah, brilliant case study. A couple more questions. One is, I'm sure you have, but the question was, do you have any midwives on staff?
Yes, yes. So all of our flight nurses have to be midwives, midwifery trained as well. So from the retrieval point of view, we not infrequently go out to a remote community and have to actually deliver the baby. Even it might be a smaller hospital that doesn't have midwifery services, but we also provide primary midwifery as in antenatal care as well.
Yeah. Probably for Jenny, what's the typical caseload for your facility over a week? I know there are loads of different services, but do you sort of measure yourselves on some sort of typical caseload that's excluding the emergency retrieval sort of work?
So I think probably the simplest way to talk about it, we've got a couple of different parts of the business now. We have the GP service in Broken Hill. We've got all the mental health services separately, but when we go out to clinics, they may see 5 patients in the day, they may see 25. It depends how many are booked in. Some of the clinics, what they'll normally do is that they'll go to a location, they'll go to 1, 2 or 3 locations in a day and drop staff off. So, during that day, they might be doing a half-day clinic in one place and they'll see sort of a few, whatever's booked in. But, it can be up to sort of 25. And 25 is the numbers I'm talking about sometimes that the doctor will see. That's a huge day for the doctor when they go out and they come back. On top of seeing the doctor, they'll see the mental health staff, they might see the nurse, they might be with the Aboriginal health workers. So, there's like when you add all of those figures together, it is a lot.
Fantastic. Yes, delivery of services. Last question is, with the remote distances and of where people are based and where they've got to travel to, and with the on-call type activities that many of your staff have to cope with, is recruitment a problem for you or not really?
Look, Randall and I can probably both comment on this one. Yes, it is. It's a challenge. It is something that we are constantly doing. So, you know, we have periods where we probably are reasonably well staffed, other periods where we're really struggling. At the moment, we do have challenges because spare staff have all moved into providing vaccinations and doing, you know, part of the whole COVID response. So, look, it's always on our minds, and we're always trying to look towards the future and actually put in place recruitment processes and things that will make it an attractive place to work into the future.
And it never ceases to amaze me. It's the best job in the world for a doctor, and we struggle to get doctors. In fact, we end up recruiting a lot of UK doctors, and I actually noticed one that we've actually recruited is actually on this, is one of the participants. I saw her name there, and she'll be coming out in a few months. So it's a struggle. It really is a struggle. It's been in the news a lot lately in Australia, just about how hard it is to recruit, and there's a shortage of rural doctors. Yeah,
well, it's I can understand that with the pressures, but as you say, it's a unique job in its own right. You do a wonderful job. We're out of time, unfortunately. We promised to our participants we'd finish in 45 minutes. We've gone 1 minute over that. But before I finish, I'd like to thank Randall, Jenny, Vanessa, and Emma for the time you're putting into this, your professionalism coming through. The work you're doing is so fantastic, and we just really appreciate you getting up at sort of 5:30, 6 o'clock in the morning to educate our UK audience on the fantastic work of the Flying Doctor Service in Australia. There are a few people behind the scenes that I'd love to thank as well, and they include Cal McGregor, Natalie Fandel, and Robert Green. And in the UK, Louise Mully, who is a trustee of ours, but is the National Director of the Britain Australia Society, who's been instrumental in getting the invitations, the marketing out and the invitations delivered to the registrants, and her colleague, Marina Kinsman. And Damien Walsh, the chairman of Britain Australia Society, has also been very supportive. I hope the audience have enjoyed the chat we've had with the 4 experts in the Southeast section. We really appreciate it.
Peter, I'm going to be very rude and jump in. Can I just thank all of the Friends of the UK for what they do? I mean, it really, we cannot provide the service without the donations. So I think it's incredible what you're all doing. So thank you. Sorry, Peter, back to you.
Brilliant. Well, on that cue, if anything you've seen and heard of in this webinar encourages you to send a few bob to the RFDS Friends in the UK charity, you can be sure it's going to go to Australia and continue the good work. So for now, it's farewell from us, farewell from the people in Australia, and thank you everybody who has signed up to the webinar and people who have delivered it. So cheerio all.